Now the hall is shifting from heart of Kolkata to rural side, say Kuch Bihar, Bashirhat. We are now in a countryside rural setup, and the patient has come with a heart attack, with a STEMI. Now how to deal with that? Our expert panels and the presenter Dr. Shuni Banerjee will show you in next 40 minutes time. Dr. Shuni Banerjee, please on the stage, along with the expert panels, Dr. Pradeep Kumar Deb, Dr. Robin Chakraborty, Dr. Kanak Mitro, Dr. Prakash Chandra Mondol, and Dr. Raja Nag. Please take the stage, sir.
Good morning. Now, it is a difficult issue for the not only for the cardiologist and but also for the public health persons to deliver the proper healthcare to STEMI patients in the countryside. We all aware of the guidelines that first medical contact, door to needle time, all in terms of minutes. But like me, who have the experience of working in a countryside, it happens that the first medical contact occurs not in hours but after days. They meet the doctors usually in a 3 to 4 days after that happens. So it is a real problem, and our scientific committee chairperson, Dr. Soumitra, has rightly entrusted the dynamic cardiologist, Dr. Shuni Banerjee. So in the next few minutes, she will address this important issue, how to deliver the proper health care to STEMI patients in the countryside, especially in the background of our...
Thank you, chairpersons. So this has been actually discussed by Dr. Soumitra Rai only few months back in UCD. So I think I have go through this discussion in 4 paragraphs. Number 1 is how you recognize acute coronary syndrome, although I don't think there is anybody who is practicing in periphery in this hall, but still, I mean, that's an unfortunate story. The second thing, paragraph will be a case, and I will stop in between and take your opinion. That is a real case. The third one is also a real case. One is anterior MI, another is inferior MI. And the last paragraph I will just touch up that how we can combat this situation and we can circumvent this problem. So why it is relevant? Because the first slide goes way back 1977, where it has been shown that early recognition is important to save the muscle. So as Dr. Mitra was saying, that it's not the question of hours, the patient come after days, and that's a bigger problem. So whatever we have to do it very fast. And although this seems to be very basic, but still let's recapitulate the discomfort zone which the patient gets in a patient with acute coronary syndrome. So it may be right time to depict this thing in your chamber rather than just focusing more on lung cancer, breast cancer, and hypertension, diabetes only. So this is probably relevant, although not been highlighted, but atypical presentation of acute coronary syndrome is a devastating sequelae most of the time brings it. So what are those? Indigestion, vomiting with or without perspiration, syncope. It is particularly indicative of a inferior or right ventricular MI, or even a anterior MI with a ventricular arrhythmias. Shortness of breath, and the most worrisome, if you don't have chest pain or symptom, just uneasiness. Who comes with atypical presentation, that we have to take in mind. And probably it is good that if these patients come for a routine follow-up, all diabetic patients, give them a warning that although your heart remains okay at the present moment, but be careful, you are a person who can have a silent myocardial infarction or who can have a painless or atypical presentation of acute myocardial infarction. Similarly, in patient with chronic kidney disease, and the rest of the others are we know, but chronic kidney disease and diabetic populations are very important, and you need to tell them very clearly. And what is the importance of this atypical presentation in Western country? It is quite big. We don't know what is in our situation, our scenario says, but they are at increased risk of sudden cardiac death also. And this also I need to tell you very clearly that these are the ECG changes, and more importantly, please remember that the criteria of giving any thrombolytic therapy which is relevant in patient who stays in periphery is more than 1 millimeter in limb leads and more than 2 millimeter in precordial leads. So probably more often you miss inferior wall MI, not the anterior wall MI, and exclude the patient doesn't have any hyperkalemia or the patient doesn't have any left ventricular hypertrophy. This is being well discussed but less commonly seen in clinical practice, LVB presented with MI. Now there is a tendency to check for troponin I very quickly. Please don't do that. It doesn't rise immediately. So how in a periphery you think the patient is having a STMI? If the patient has been survived with a cardiac massage just before the chest pain, and this is the ECG, this is a STMI, and these are high risk. If the patient is having a localized chest pain and after 4 to 6 hours you see the troponin is normal, it is likely non-cardiac, and these two are, all these three are in gray zone, so you need to pick up appropriately these patients. And don't forget the other diagnosis of acute coronary syndrome. As a periphery practitioner, this is important rather than jumping into the situations. So more important is that remember herpes, anemia, chest trauma, even peptic ulcer disease, tension pneumothorax, this can happen. There is some people who can have episodic paroxysmal tachycardia presented with angina. Now this is a brief description of two particular patient. Case 1, who presented after 36 hours, the culprit artery was flowing, who has been taken to our center for a angioplasty. We did an angioplasty, and after 2 weeks the ejection fraction was normal. The other patient with the same proximal LED occlusion, who presented within 2 hours, we did everything, but the ejection fraction after 2 weeks remains low. So as a periphery practitioner, what you are supposed to do, try to achieve a flow in the artery. Now with this summary or introduction, we go into a case which is a very relevant. Like this Sunday, this gentleman who is hypertensive felt excruciating chest pain after breakfast, and he stays quite far away from Kolkata without any facility for cardiac cath lab. He consulted physician Shun, and he has a history of stroke 6 years back. This much he says, that I went in the hospital, I stayed for 2 days and I had a stroke. Then when the doctor was asking that what is the stroke, what you had, he was unable to specify what it was. He says that I can't remember, my daughter may be well aware of all these reports. So I have told her to come. She has been married and she stays nearby only. So she is meanwhile supposed to come with all the reports. In the meantime, the patient is becoming more sick, and so the chances that a patient has acute coronary syndrome is very high, and this is the ECG now which has been taken at that particular time. Yes. So, sir, 4 of you choose who is going to answer this question. This is the ECG and this is the clinical background.
So, the patient is suffering from, in fact, hyperacute anteroseptal MI in an area 80 kilometers away from Calcutta. Sunday morning, traffic congestion will be less, but still it is there. It will take more than 1 hour at least to reach any PCI capable center. The question is, and the patient calls the doctor at 45 minutes. So 45 minutes plus if I take 1 hour at least. So I think that it is unlikely that he will reach the PCI capable center by 100 minutes or 120 minutes, unlikely. So I would rather advise the patient to go for thrombolytic therapy in his location. I
think the only problem here, the patient has a history of stroke which is not known, what kind of stroke was it?
Yes. That thing is that history of stroke is a non-specific term. If it is cerebral hemorrhage, then we have concern. But if it is cerebral thrombosis and if it is beyond 3 months, that I am not concerned.
That is 6 years back, so it doesn't matter.
Yes, it doesn't matter, yes.
One thing I like to add with, I fully agree with whether we will give thrombolysis or we will transfer the patient with the arrangement of pre-hospital thrombolysis. On the way we will start thrombolysis so that they can reach earlier to the hospital.
Only
rather
point
than
is 80 kilometers away from the
So,
PCI capable
80
centers.
kilometer is not the factor. Factor is from where it is 80 kilometer. So
Yeah.
sometimes 80 kilometer may take 3 hours to come. So I think it should be a pre-hospital thrombolysis to reach the PCI capable center as early as possible.
I think before we discuss, can I have some quick audience response? Let us say this was a hemorrhagic stroke 6 years ago. Right. So we do not know. So who will favor thrombolysis? Let us say it's a hemorrhagic stroke 6 years ago. Anybody? So
For hemorrhagic thrombosis, in fact, there is no time frame. But for purpose cerebral infarction, there is time frame of 3 months.
if it's a thrombotic stroke, fine, acceptable.
It is 3 months.
But the hemorrhagic
But
stroke.
for hemorrhagic stroke, there is no time frame. There is no time frame.
So anybody would dare to give thrombolysis in this case, assuming that patient had a hemorrhagic stroke 6 years ago. Any
I think-
comment from the Dr. Goh? Can you just come up quick comment?
For the benefit of discussion, I have just switch over this
I know
slides.
that you are a
to-
naughty man.
No,
This
I
is
thought so that we
if
can
it is
recapitulate.
known that this is a hemorrhagic stroke, I am not going to give thrombolysis. That is undoubted, there is no question on that. But if it is a thrombotic stroke, 6 years back, there is absolutely no contraindication there. So one need to know whether, yes? In that case, one has to give a benefit of doubt and try for PCI if it is feasible. It is for the safety of the patient.
PCI is
Dr.
not feasible
If
here.
it is not known whether it is a hemorrhage, it was a hemorrhagic stroke or a thrombotic stroke, if you don't have any records of that, in that case perhaps one has to give the benefit of doubt that it might have been an hemorrhagic stroke and send the patient for PCI for the safety of the patient.
How long he has been hypertensive, Sunit?
He is hypertensive for last 10 years.
10 years.
Yeah,
And is it controlled?
it's good, under control. He's
Then-
on
then
Now,
no
but what was the
problem.
blood pressure status during this 10 years time?
the 10 years time. The blood pressure was controlled on amlodipine, thiazide diuretic, chlorthalidone he was not taking,
No, blood pressure status despite medication.
below 140/80, and he showed
is-
the chart.
Any neurological deficit?
No,
Okay, Arunangshu.
So if the blood pressure is controlled, no problem. We'll go ahead with thrombolysis.
Arunangshu.
Konokda, any idea as to the drug to be used for pre-hospital thrombolysis in a rural setting of us? The drug that in mind.
Look, in the rural setting of India, in fact, I had been gone through the Bronwell's book during the last few days. Regarding streptokinase, I think the issue of streptokinase will come in this scenario. 3 lines is written. One is that it is practiced in some parts of the globe. Number 2, streptokinase is not used in USA. Number 3, it can be used in some situations like say asymptomatic young patient with influenza infection or a very elderly person where the risk of bleeding is too high. So these are the situations. This is the only thing written in a textbook with streptokinase. But in our scenario, because in some parts of the globe means in this part of the globe, we still use streptokinase. And we are compelled to use streptokinase in rural situation, particularly due to compelling situation of finance.
I think just let us
And
just
another thing is, although it is a class 2A indication, it is not a class 1 indication, pre-hospital thrombolysis. But our practical experience in Ajikon Medical College, we get plenty of patients referred from Bosirhat and Barasat with pre-hospital thrombolysis, and we get them in a better way,
Which
better
thrombolytic
state.
is used? Which
They
thrombolytic?
use streptokinase.
Streptokinase.
Dada,
Obviously, it is streptokinase.
a point to note here. See, we give a thrombolysis in that setting only. Try to find out whether it is a successful thrombolysis by the criterias. If it is a successful thrombolysis, there is no need to hurry the patient on that particular
No,
point.
one thing, I am telling that if you want to observe the patient, it will take another 1 to 2 hours. So what is the need to take this patient in a peripheral setup
Sir,
to
sir, when you
lose
throm-
another 1 to 2 hours?
So when you thrombolyze with streptokinase,
So we have
do a delay, rescue PCI, the risks are far-
Soumitra, can I have a quick
much
comment
higher.
from you?
No, I
Vikas,
think,
can you come front?
I think Dr. Mitra, are we confusing the terms? What is pre-hospital thrombolysis? Perhaps what you are talking about is a thrombolysis given in a peripheral center.
No, 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 no.
Is it in ambulance?
No, no. It
So
is
who is giving the thrombolysis?
pre-hospital means before arriving the hospital in a
Any
pre-hospital
hospital
means
He is talking of
Not a
Sumitra.
cath lab hospital.
Yeah.
Any hospital
Soumitra,
or primary health center.
I think he is saying that before reaching to tertiary
Yeah,
care.
anywhere before.
any tertiary hospital.
That's why you are
Before.
confused.
It's not
That is not
tertiary
pre-hospital. That is not pre-hospital
Fine.
thrombolysis.
Tertiary
Pre-hospital thrombolysis means in the ambulance. Patient
Yes.
hasn't come to any even primary health center. If it is given in primary
Yes,
health
yes,
center, it is
yes.
not pre-hospital.
So if
I think
a-
we should
in
not
hospital, I
confuse.
think that is a
If
small
a
thing.
thrombolysis is
Because
given in a
quick-
primary health center, then will that be called in-hospital thrombolysis?
Because can you have?
Yes, why not?
No, no,
Why
can I,
not?
can I
Okay,
comment?
just, Arupta, just a minute,
Can I comment?
Because can I have a quick comment from you?
Now, very clearly, pre-hospital thrombolysis means, now you have to understand how the mechanism started, the primary PCI and the thrombolysis in the community. Now, it comes from the Western world where a person gets a chest pain, calls the emergency number, within 8 to 10 minutes an ambulance reaches his home. The ambulance personnel does an ECG and he diagnoses it is an ST elevation MI. No doctor is needed. That ambulance crew, when he diagnoses an ST elevation MI, he takes the patient into the ambulance is equipped with a monitor and a defibrillator, and he gives a 10 hectoplex injection.
Right.
That is
That is pre-hospital.
Yes,
absolutely.
That is pre-hospital. Next,
Clear.
Orunangshu
Arupta,
that is
quickly.
Orunangshu
Actually, what
answer.
I was thinking
Orunangshu
about,
comment.
In our
Now,
country,
second
such
thing,
trained personnel are not
One minute, one at a time. Because you
second
finish.
thing, Orunangshu
Arupta, just a minute. Hold. Let him finish.
So Orunangshu Das comment that streptokinase has been given in a nursing home. So what's the hurry of shifting that patient to a bigger center? Now if it is a successful thrombolysis. Now if you go for the current guideline, there is a hurry. Reason being, the best treatment today is primary PCI, we all know, if we can deliver it within 120 minutes from the first medical contact. In this particular patient, which we can't do. For example, what is the alternate best treatment based on the STREAM trial is pharmaco-invasive strategy. Now, what is this pharmaco-invasive strategy means? Means, the definition is very clear, there is no ambiguity. If a patient with chest pain presents within 3 hours of chest pain onset in front of a doctor, the doctor thrombolizes the patient. Irrespective of the success of the thrombolysis, that patient should be transferred to a tertiary center with a PCI capable facility to have an angiogram and subsequent
That
revascularation
is
within next
exactly-
24 hours. That is the definition of pharmaco-invasive strategy.
Yes, yes.
That
Okay,
is
just
the
one- okay,
definition
because
of
take your seat.
pharmaco-invasive
I have
strategy.
some reservation here.
Yes,
It
that
is-
is absolutely
Okay,
right.
because, okay.
Now,
In pharmacoinvasive therapy, a PCI should be done between 3 to 24 hours.
Yes.
If the patient can be shifted within
Yeah.
1 hour, I don't do anything there because
no.
of the risk of increased myocardial hemorrhage. So we have to wait for 3 hours after giving an thrombolytics.
now that's again.
Before I can go for this thing. Exceptions are there. If there is an unsuccessful thrombolysis, rescue doesn't require any waiting.
I think that is a
No, no,
different
no.
story. That is
No,
rescue
no,
PCI.
Doctor-
That is a
Doctor
different
Guo,
story. Yes.
Rescue does not require any
is a
waiting.
different story.
But
That's a
for
Okay,
different
a
fine.
successful
Anjana-
thrombolysis, it should be
Anjana,
done between
quick comment.
3 to 24 hours.
Quick comment.
I have a small comment. Whenever we talk in terms of pharmacoinvasive, we think that you can buy time, but that is not the case. In STREAM trial, all the thrombolysis was done within the 3 hours of chest pain. That is important issue. To get the best result, even in pharmacoinvasive, you must do the thrombolysis within 3 hours. Number
And-
one.
and the next comment,
And
these three-
these thrombolysis are mostly with the tenecteplase or fibrin-specific lytics. Whether if you use streptokinase, whether it
Yes.
will give good result or not, we don't know. But our Chennai registry, from the ACS reports from the Chennai in India, they are doing pharmacoinvasive on the basis of streptokinase thrombolytics, and they are getting very good results. So there is evidence to have pharmacoinvasive even with streptokinase.
Okay, just quick, because
Now-
just quick, very short, very short.
Very short. And why this 3-hour gap? Why this 3-hour gap? Why not within 3 hours? That is because we had the adverse outcome with the ASCENT-4 trial with the facilitated PCI. So we shouldn't be doing any PCI within 3 hours of thrombolysis,
Sure, absolutely.
but it should be
Okay,
after 3
Dr.
hours.
Dr. Vishwas, you had a comment, and sorry, can you just continue with your presentation?
Okay,
Can
thank
you
you.
continue with that?
No, I say one thing in between, that this is not a case which is built up. It is a true case, and I was actually involved in the decision making and the doctor actually sent me this ECG and gave me the clinical detail that what I should do, you tell me, and that's important. And this is the, by in short nutshell, the contraindication for fibrinolytic. Remember, any prior intracerebral hemorrhage is a contraindication for fibrinolytic that we need to keep in mind. Rest of the things we know. Now, the thing is, what I told him that, okay, you try this antiplatelets, antithrombotic, and high dose statin and nitrate and repeat another ECG and send it to me. He did it. Now what happened in between, he said that the chest pain has increased, heart rate has increased to 110. You see that ECG was showing a heart rate of around 70 and he has a non-sustained ventricular tachycardia. He becomes hemodynamically unstable. So what I should do? I don't know the CT scan report, and I asked him repetitively, you had any neurodeficit? No, I had mild headache, but they did a CT scan. My daughter will be coming, so she is alone in home. So all this thing is happening. Recapitulate what I should give as a adjuvant therapy before we are starting thrombolytic or when we are initiating thrombolysis. So this is the aspirin, remember very clearly, and clopidogrel you should give, and there is no indication as of now of ticagrelor, and prasugrel we know we are not going to give.
So from this treatment regime, it is apparent that you are going to take the patient conservatively, because if you want to do PCI, then the loading dose should be given 600 milligram clopidogrel, but you have given 300 milligram.
Yeah.
So what is your mind?
Okay, fine. So in between there are three things which came from this senior practitioner. That number one, this person is 60 years on the verge of his retirement. He is a employee in one of the government sector, West Bengal government sector. So finance is not an issue, but somebody has to take a decision.
Retirement has got nothing to do with the dosage of clopidogrel.
No, the issue is very clear. Today is Sunday. I don't have a credit card. So if I have to go, I have to call my daughter and my in-law, and they will take a decision. These are all logistics. Now the thing is, so do something. I don't have a money right now, but the thing will be arranged. So see, the thing is, the primary physician wants to thrombolyze. I told him that make it sure that it is not a coronary artery spasm still, and just wait for a minute and give these things and repeat another ECG. And in between, this thing happened. So naturally, now the thing comes very clearly that we have to thrombolyze. Yes. When I decided to give clopidogrel and low molecular weight heparin, we are thinking of thrombolysis. He said that I have this thing in my basket. Can I give it? I told him, see, the thing is that we don't know what is the status of the brain. But he has been given both the choice, and the patient opted for this thing. He said, you give me the best. But give it right now. I want to just get some benefit. I am not been able to tolerate the pain. And along with this, the adjuvant therapy, what was given is enoxaparin in this patient. And let me go to this thing. And this is a very meticulous discharge certificate, not done by me, by those doctors. And I wanted to show you that a periphery doctor who resides 80 kilometers away, who practices medicine, can give such a beautiful prescription. Injection Rediplex 10 units over 20 minutes, 1:45 p.m. repeated at 2:15. Clopitab, atorvastatin, ecosprin, Clexan 30 milligram IV, and then 30 milligram subcutaneously. And injection metoprolol, 5 milligram slow IV. Infusion nitrate, moist oxygen with BiPAP support. Injection morphine, midazolam infusion. The only thing, he gave this thing also. So you see how meticulously they have managed the patient in the periphery. And the take-home message is very clear that along with thrombolysis, you need to give proper adjuvant therapy. This is true for anterior MI with a high sympathetic tone. Although the blood pressure was well controlled, but when the heart rate went up to 100, the blood pressure also shoot up. So one point we can ask that whether giving beta blocker in that position is okay or not.
Just hold on for the time being. Soumitra, just before you comment, Just two observations. One is regarding thrombolytic therapy. If you could sort of discuss the data that we have from the Indian scenario, pharmacokinetic data, and what number of patients have streptokinase, another number of patients have non-streptokinase, like reticulase, tenecteplase. Any comment from that? Soumitra Kumar, then Soumitra Roy.
Yeah, I spoke about these issues with Dr. Ajit Mulasari, was doing the STEMI India things. Almost 70% of their cases are on streptokinase. And only difference with streptokinase with pharmacoinvasive is instead of 3 to 24 hours, they are making it 6 to 24 hours. So 3 hours extra wait once you give streptokinase. Another issue is here, when you do not know the status of the stroke, but we are still giving some thrombolytic, streptokinase causes less intracranial hemorrhage than reticulase or tenecteplase. People tend to believe that streptokinase is a general bleeder, but streptokinase causes less ICH, significantly less.
Absolutely.
So perhaps when the
Well
status
said.
is unknown, streptokinase may be a better choice.
Absolutely. So this should not be have been the first.
Yeah, sure. Yeah, so that is a very
fully
valid
agree
point.
with that. Only the Clexane dose is not right here. That should be set right. And you also pointed out towards the fondaparinux as an alternative.
সৌমিত্র
which
মাইকটা
is
ঠিক
much-
মতন ধরো তো মাইক ঠিক মতন লাগা
Okay. So the enoxaparin dose is incorrect here. That should be 60 milligram subcut stat. 15 minutes later, 30 milligram IV followed by 1 milligram per kg subcut. The dose is incorrect. And number two is you can use fondaparinux, which is much more convenient. You can go back to your previous slide just to highlight the use of fondaparinux.
Dr. Dajbiswas.
Regarding beta blocker, this was very much advocated, particularly after Miami trial, but subsequently it has fallen into disrepute, particularly a patient who is going to be
और মাইকটা ঠিক মতন
Mike.
who is going to be transferred because of chances of failure, bradyarrhythmia, etc. So whether this could be done injection at a peripheral center is a
Right.
debatable
The beta
issue.
blocker person, can you take over now from here? For beta
Yeah.
blocker?
So beta blocker issues is that he persistently having a very high blood pressure just following during this before they started the thrombolysis, and the heart rate also went up. Now it is a sympathetic response or acute left ventricular failure. The point is very well taken that if you blunt the sympathetic activity, the patient may worsen. At the same time, this heart rate and blood pressure, increase in blood pressure is going to make him more unstable. So he tried 5 milligram actually, and he waited for some time. He said that he is tolerating well. So that's how he has done it. Actually, it is not possible all the time to give him a very feedback, but we are in frequent touch. So I told him that giving a beta blocker is a risky situation. You have not been able to do a echo. You don't know what is happening. But he is having severe chest pain and his heart rate and blood pressure cannot be controlled despite giving morphine. Yes. And just a minute, what Dr. Soumitra Kumar has said very rightly, which is not been given there, is that you are not supposed to give IV enoxaparin and subcutaneous enoxaparin at the same time. Just keep a 15 minutes gap in between.
Yeah.
Yes, sir.
About metoprolol, there was, after the Miami trial, it was class 2A indication till 2 years back. The latest ACC/AHA guideline has done away with the use of metoprolol. But off-label use of metoprolol can be done if the patient does not have any fluid overload evidence. With a high sympathetic overactivity with hypertension and tachycardia, if there is no fluid overload, off-label metoprolol can be used, but class 2A indication has been removed.
Right. So also we have treated the patient with thrombolytic therapy.
Yeah.
We've given the concomitant medication. We've got 10 minutes to go. What you have done next?
10 minutes, okay. Yeah, 10 minutes, lot of time. So also one important thing that in patient with impaired renal function, which is not, we are aware of these patients, you need to keep in mind. Now when we are just, they are trying to shift and we are also ready here, he said that chest pain has gone, but still it is recurring and his blood pressure still elevated. And what happened, by this time the daughter came with the CT plate. When everything has been done and we are on the verge of taking the patient in our center. So this is an old intercerebral bleed.
Bleed.
Yeah.
So what happened to the status after thrombolytic therapy? Now Dr. Shantanuga has been proved to be wrong.
No. It seems to be a hemorrhagic conversion, but what the report I found is a acute intercerebral bleed and it is a edema.
But what happened to your neurological status? Remains unchanged?
His neurological status remain unchanged.
So what you have done after that?
So
What does it prove? Does it prove that thrombolytic therapy is not contraindicated in intracerebral hemorrhage?
No, it is a chance. Rakhe hori mare ke. This we can say in this way. So the thing is that if you have done that the patient, known that the patient has an intercerebral bleed, we will never thrombolize at any cost. The take home message is very clear. Yes,
So
sir.
even still we stand
I
today,
have
we
got
will
a
not
small-
thrombolize.
A small comment over here. I don't know whether it is a myth because all trials excluded patients with known intracranial hemorrhage or hemorrhagic CVA. But what is hemorrhagic CVA? It comes from 99% from hypertension. There is no coagulopathy in the body. So if at the point patient is not hypertensive, do you think logically there is an increased chance of a rebleed with a thrombolytic?
But as of now, we are not supposed to, because, yes.
Why? Explain.
Dr. Dev, Dr. PK Dev, you got your comment.
Thrombin specific and it
Dr. Go towards Dr. Dev, he's going to talk.
Please.
Dr. Soumitra wants to have a new trial of background history of hemorrhage with thrombolytic therapy.
It should not be given because the thrombin specific ones never discriminate between the old or the new thrombin.
Correct.
So
It is
going
absolute
to
contraindication.
negate those things, and it is going to, there is a possibility of a rebleed. Yeah. So it should not be given even if it is an old one.
But one
Dr.
thing,
Dr. PK Dev.
but one thing Dr. Sunit, your CT findings is not matching with the clinical status. This is a very striking.
Yeah,
It is so much cerebral hemorrhage, intercerebral hemorrhage, but your patient is alert, conscious, and having. This is very unlikely.
it is unlikely.
At least
No,
in
I
the
agree.
acute setup.
No, the issue here is that the patient presented with infarction. And at that time, CT scan was not available. So we did not know that there is a cerebral hemorrhage. So I think in that situation, had I been there, I would have used the thrombolytic therapy.
Yeah.
So anyway, so what you have done after, so anyway, you have done that?
No,
Nothing has
I have
happened?
done. I just wanted to say that the patient is now in my lab and it's ready for taking for angiogram because he is having ongoing chest pain. And actually, I should think of one only issues. This is a very latest statement from European Heart Journal that if you have a atherothrombotic event ACS or PCI less than 8 days ago, the risk of thrombosis is high. Low chances of bleeding we have to forget. Now this patient has been with stable hemodynamic, but the chest pain is discomfort is persisting. And the thing is, they have been given a feedback to me, now the angiogram is required and something has to be done. And now you need to do at least an angiogram, what you should do.
No.
We did an angiogram with bivaluridine.
No,
Support,
Sunil,
yes.
there was normalization of the ST segment.
Yeah, but he's
And,
having,
and at the same time, there was ongoing chest pain.
yes.
It's
And
very-
this chest
very
pain is not
peculiar.
pleuritic.
Very peculiar, yes.
Yeah. And the reason being this.
Another question, another comment. What is the rationale for use of bivalirudin in this situation? Practically, what is the indication of, at current scenario, what is the indication of bivalirudin?
Because see, the thing is this patient
Especially
has,
in the background of hemorrhagic stroke.
the thing is that if, now you don't know when the patient is going to have a neurological symptom.
The only, sorry.
No. There is a definite history of stroke.
Yeah. No, we did a angiogram with a bivalirudin bolus dose, not giving heparin.
Now, what is the rationality of
Rationality
giving-
is we thought that the patient has received a low molecular weight heparin, enoxaparin.
So you
12 hours,
anticipate
it is almost 12 hours by
you,
this time.
you anticipate excess thrombus load or some high risk
No.
High risk
coronary
of bleeding, high risk of bleeding. That's
No,
why I
the,
divided.
the whole idea of choosing bivalirudin, although the data is not that supportive as of now, from his point of view, since the patient, now he knew that patient has got a hemorrhagic stroke, patient has already been thrombolized, patient has already been treated with low molecular heparin as well as sort of antiplatelet drugs, so he was a bit cautious between sort of choosing the other drug as compared to bivalirudin. That is probably the reason.
Chairman, sir, there is only one theoretical consideration of justifying bivalirudin is on the basis of the acuity trial. The acuity trial had definitely shown a much lesser incidence of hemorrhage compared to heparin or even GP2B3 receptors with or without.
exactly.
So, that is a theoretical
Sure.
basis. But then this is very difficult. The one thing I would say, I agree with Dr. Pradeep there, the many a times we use the word post-MI angina to justify our going for a coronary angiography days after MI when the patient is practically clinically stable, both clinically and
Sure.
electrophysiologically.
I think that is quite acceptable. Before you just proceed to the next one, you got another 7 minutes. I just come back to the point which was discussed by Bikash and Shantananda earlier, that let us say patient was stable after thrombolytic therapy,
Yeah.
but after thrombolytic therapy, from that primary center, patient was transferred to your hospital,
Yeah.
let us say within 2 hours time. At what point you will do the invasive study? Even if the patient is stable, will you do it immediately after 3 hours, 12 hours, 24 hours?
I will
And-
try to wait for 3 hours, but if you have a failed thrombolysis, you
No, I'm
need
not
not
talking
wait.
about thrombolysis. Patient
No,
is
it is a
stable.
case of
Stable, at least you have to wait for 3 hours.
3 hours. So
Yeah.
you will do at 4th hour, you will do an angiogram.
Yeah.
Right. Now, is there any data supporting that? Anybody believes that the patient is stable after giving thrombolytic therapy, now you have to do an angiogram. Will you do it after 24 hours? Or a pre-discharge or never angiogram at all? What is the current status? Any comment from the floor?
no. Before that, I want to know why 3 hours.
Why 3 hours?
There should be justification for delay of 3 hours.
No, that-
so
that, he-
because the 3 hours is necessary, because during that 3 hours there is high bleeding risk.
Yeah.
Because we are using aspirin, clopidogrel, enoxaparin, so there is high and also thrombolytics. So there is a condition of high bleeding risk. We want to avoid that period of dangerous period
Yeah,
where
just-
the bleeding
exactly.
will be too high.
Dr. Dev, I'll beg to slightly differ. There is a high hemorrhagic risk, but also there is a secondary overreaction of the platelet activity. So side by side there is an increased platelet activity, so there is a prothrombotic risk as well. So 3 hours is not for hemorrhage, more for prothrombotic milieu. Because within the 3 hours, the angry elements of the blood becomes more angry, and you take time to subside them.
In
And
fact,
this is both prothrombotic as well as hemorrhagic.
Yes,
Excellent.
It-
Because can we add to
3
that?
hours is both prothrombotic
Exactly,
and pro-hemorrhagic,
exactly.
both.
It is-
so
it is
so that
more
is
of a
not
thrombosis.
exactly the perfect time for intervention.
It is a reocclusion versus bleeding.
It is a reocclusion of the SN4 in the facilitated PCI trial when all the patients had half dose thrombolysis followed by angiogram within 3 hours. Those patients had adverse outcome because of reocclusion.
Correct. So what is
Not
the
because of
time
bleeding.
at which the reocclusion rate is higher as compared to bleeding rate? There is a time in intervene.
So
Go
that's why 3 hour is not 3 hour window is always given. So
Sunil, how
yes,
desperate-
so
3
I
hour
believe-
3 hour window is not necessary only in case of rescue angioplasty.
Yeah, absolutely. Yes.
Sunil, how desperately the patient needed intervention in this case. With that ICH, once has been spotted, now you will be giving aspirin, clopidogrel, I mean anyway I suppose after ACS, but with a stent in situ, you will be compelled to give dual antiplatelets.
Yeah.
So with that ICH in the brain, do you justify your step?
No, but we have not, we need to see the coronary anatomy
Okay, you
very
have seen
clearly.
it. Now what was your
No, I
decision?
tell you one thing. You can see only the arteries flowing. Actually, it is a TIMI2 flow. It's not a TIMI3 flow. So that's the reason
But
of
the
this
risk
angio.
benefit ratio,
Yeah.
leaving it at TIMI2 and putting in a stent
No,
and
I have
doing
not
dual
put any
antiplatelet.
stent. I mean, I am waiting.
No, he's
and
not
there
done
is
no stent. He
a
has done
CTO in the
angiogram.
right
Soumitra
coronary
Rai,
artery.
quick comment, Soumitra Rai.
CTO in the right coronary artery.
Firstly, 6-year-old ICH is not a contraindication of DAPT. Number one. Number two, it's a serious question. 3 to 24 hours is the pharmacoinvasive window. Is there any data? 3 to 6 hours, 6 to 10 hours, 10. Is there any benefit?
Because can you just add on that?
No,
Your comment.
I am not aware of any data for 3 to
There is
6
no
hours.
data as of now.
That's
No
not-
data as of
so-
now.
so-
Sunil, can you finish?
Rakesh, yes.
Okay, Rakesh.
Just a comment, sir.
Rakesh.
The streptokinase, the lytic stages are 24 hours. With ethyl paste, you can go ahead within 3 hours, but if you have given a streptokinase,
Exactly.
you have to wait for a longer duration. That is the message.
Perfect.
I think the most important issue here is to take the opinion of a neurologist and come to the conclusion whether this hemorrhage is in ruin, fresh or the old one. Because that is the crux of the whole problem.
Dr. Shantanu Guha.
Firstly, the transfer AMI trial based on which this thing was initiated, they recommended to send it after 3 hours and to do it between 3 and 6 hours. And in the other trials, it was from 6 to 24 hours.
Beyond
so they
3 hours.
clubbed,
Beyond
it was
3 hours.
clubbed.
True. It is only transfer
None
AMI
of them
trial.
said before 3 hours and none of them said beyond 24 hours.
Correct.
That is number one. Secondly, regarding streptokinase, we have a good data from the COVI project, which was done in Coimbatore by Thomas Alexander and Ajit Mulasari and all. What they did after streptokinase, they kept this period for 6 hours and did the plasty after that. But coming to your case, this patient is having a flowing LAD.
Yeah.
If it is a flowing LAD,
TIMI2 flow.
But TIMI2,
Yeah. Not TIMI3 flow.
But
I can't
he
say
was getting
you.
angina.
that
Okay,
is-
we got
that's the
two- we
reason
got
of
just
this
1.5 minutes. Sunil, can you finish?
one should be very cautious of doing a plasty here because you have to give at least 6,000-7,000 heparin or equivalent.
No, patient is having angina.
We will read
Dr. Guho, this patient is having angina. Patient is symptomatic, post-MI angina. Sunip, can you finish the case? You got 1.5 minutes.
So what we decided that we fix the. Huh?
No, finish. He has taken.
No,
he has taken. You got only 1.5 minute time. You have to finish the case.
We didn't do anything. What we did is that. Okay, sorry. What we did is that we put the stent into the LAD.
Right.
And after 5 days, we made it sure that he didn't have any neurological new event, and we did the right coronary CTO. This is exactly done in April last this year. So he's doing extremely well. So we have almost time. So I just.
Sure. You got a.
I just need to focus on few things. Forget it. I am not discussing this case.
Go to the conclusion slide, take home message.
Yeah.
Take home message.
Yeah, take home message. The take home message is this. The people says that if you reach within 90 minutes, still you do a coronary angioplasty, which is not possible in our country. Within 30 minutes, you thrombolize. So, not 2 hours anymore. You need to do PTCA, PTC and PTCA. We need more PTCA center in our country. And what we should do in the early hours, recognition and risk stratification. Awareness of both doctor and patient is important. And dual antiplatelet, not prasugrel. Remember, this is a back tendency. You can give ticagrelor if you are not sure that the patient is having ST elevation MI. If you have a ST elevation MI, stick to clopidogrel, high dose statin, and then give this other drugs. And probably ischemic condition, in which has not been discussed very frequently in our country, should be promptly done. When the patient is coming to the emergency, ask somebody to inflate the BP cuff for 15 minutes and deplete in both the arm. Probably this may be a future. Feel free to consult.
No, Sunip, I
Thank
think,
you. Dr.
I think, no. I think the take-home message should be what should be done in a rural scenario.
Yes,
Yeah, that has been totally missed.
Can you
That has
conclude?
been
Dr.
totally
Dev,
missed.
Dr. Dev, can you conclude? Can you conclude the session?
I think in both the scenarios, in fact, if there is no contraindication to thrombolysis, and if we get the patients within 2 hours, and if there is no PCI capable center within the reach within next 100 minutes or 120 minutes, then we should go for primary angioplasty. No, go for thrombolysis. And in rural areas, we should always go for thrombolysis, and in our country, particularly in West Bengal, more so. In fact, the streptokinase is the thrombolytic of choice.
Yeah.
So in this scenario, we should treat with streptokinase, and with streptokinase, there may be successful thrombolysis, may not be. There will be 65% successful and 35% failed thrombolysis. If it is a failed thrombolysis, we will transfer the case immediately to the state or to the PCI capable center, because in that is the case who needs immediate intervention, failed thrombolysis. And if it is a successful thrombolysis, hemodynamically stable, symptomatically stable, electrically stable, we can wait. And we will take time to transfer the patient to the district hospital or to the city hospital.
Thrombolysis is a must, but early recognition.
But if he is symptomatic, then we will transfer the patient to the
Actually, our last NIC data states only 10% undergo primary PCI in our country at present. This is our latest primary NIC data.
No, just one last point you want to say something.
Sir, I have practiced in the periphery. So a very commonly asked questions by the peripheral physician is that when to give a low molecular weight heparin after thrombolysis is being done. And they categorically avoid giving enoxaparin for the next 6 hours or so.
No, so simultaneous. It
should be given
adjunct therapy. Within a 15 minutes interval of subcutaneous.
To prevent reocclusion, it should be given.
It should be. And the thing is, I absolutely sum up with only one comment, is that thrombolysis has to be utilized more commonly and more successfully. But the problem is the awareness. That is the problem.
Absolutely.
So,
I think it's a brilliant session. Brilliant session, Soumitra. You have done a wonderful thing, and Sunip, well presented. And thank you all participation from the audience. Have a wonderful day. Thank you very much.
Excellent job. Couldn't have been better.